Hello, everyone, and welcome to the International Online Spinal Cord Injury Research Series. This is Bethany Condilis broadcasting for you today. Just a couple quick announcements. You might have seen some of the flurry, but we're very excited to announce that we have some very special upcoming programming in collaboration with the International Spinal Research Trust. So that'll be starting September 8th. So we have some special programming, some special speakers, all with this fun partnership for the month of September. So please make sure to tune in and keep up with the details as we roll out more about who will be speaking. As you probably know, we have plenty of links for you to check out. You can nominate speakers, you can sign up for emails, you can follow us on Twitter. All of those links and everything are in the video description. And so without further ado, we've got Jaki DeFinis, who's going to be moderating today's session. So I'm going to turn the show over to her.
Okay, thanks, Bethany. So today I have the pleasure of introducing our speaker, who is Dr. Dennis Bourbeau from Case Western University. So Dr. Bourbeau received his Bachelor's of Science in Biomedical Engineering from Worcester Polytechnic Institute. And after that, he went on to receive his PhD in bioengineering from the University of Pittsburgh, where his work largely focused on ventral root and DRG microstimulation. From there, he became a research investigator at the VA Medical Center in Cleveland, Ohio, and then in 2016, a staff scientist at the MetroHealth Medical Center, also in Cleveland, Ohio. And then in 2017, became assistant professor at Case Western University School of Medicine. So among many of these roles, somehow he has found time to talk about his work today with us, which involves looking at neurostimulation approaches for bladder control after spinal cord injury. So before I hand things over to Dr. Bourbeau, I just want to remind everyone, if you have a question in the chat, please just put your question with the little Q next to it, so I know, just sort of look for it in the chat. And then we do have at least 2 little break sessions set up, so that sort of after the intro and a little more data, we're going to stop and answer as questions as we go along. And then since we probably won't get to all the questions at the end, Dr. Bourbeau has agreed to sort of stay and join in the chat and answer any questions there that he can. So with that, I'm going to hand it over to Dr. Bourbeau.
All right. Thank you very much, Jackie, for a great introduction. So I'll be talking today about neurostimulation approaches for bladder control. And I appreciate that there are a couple of things in here that I want to make sure everyone's familiar with and comfortable with. First, what is neurostimulation, and what are the techniques we're doing with that? And then, of course, bladder control. It's a pretty complicated system. So I'm sure everyone has their slide or two that they'll put up to kind of impress upon everyone the complexity of what they're working on. So this may be, I try to have a simple version of that. So the lower urinary tract, including the bladder and urethra and urethral sphincters, are controlled by somatic and autonomic neural inputs and outputs. So the main functions really come down to storage and emptying. So with storage, we have the detrusor muscle around the bladder inhibited, relaxed. We have tonic drive to the urethral sphincters. And then when someone chooses to empty, there's a coordinated micturition of the detrusor muscle contracting to squeeze the bladder and relaxation of the urethral sphincters. We have several neural targets here that we could look at for activating or modulating activity to those muscles, or picking up signals and interpreting them. So the hypergastric nerve going to the bladder is classically thought of as sympathetic and would be relaxing the bladder. The pelvic nerve is classically thought of in the parasympathetic system and would be driving bladder activity to contract. And then the pudendal nerve is under more volitional control. This is where we get a lot of our conscious sensory perception of what's going on, and where we can control the sphincters volitionally to some degree. So when there's a spinal cord injury, there's a number of things that can happen. And I'm sure all of us appreciate that. No 2 lesions are the same, and there's a great deal of heterogeneity within this population. So there could be neurogenic detruser overactivity when there's a lesion. So I'll be talking mostly about upper motor neuron spinal cord injury throughout this talk. With lower motor neuron, certainly this affects the motor efferents going out to these organs, and so things are basically flaccid. And using things like electrical stimulation is not going to be necessarily very effective because it won't be able to take advantage of neurons that aren't really healthy or there anymore. So I'll be taking the assumption this is upper motor neuron, where there's a great deal of intact reflexes and reflex pathways, and often strong or hyperreflexic activity. So the neurogenic detrusive overactivity is affecting the great majority of people with spinal cord injury, wherein a slight distension of the bladder or filling the bladder to a small amount can evoke an excitatory reflex that causes the bladder to contract, and that can result in feelings of urgency and urinary continence. There's also detrusor sphincter dysinertia. So remember, when we want to empty our bladders, that's a coordinated action of the bladder contracting and the sphincter relaxing. But with spinal cord injury, that coordination can be lost. And so there's a reflex where as urine is coming down the urethra, there's an excitatory reflex to contract the sphincters. So just as you're trying to empty the bladder, the sphincter will reflexically contract, making that difficult. So we may see a lot of people struggling to empty their bladder. Maybe it comes out as drops, or they have to use a catheter. And of course, there's diminished sensation of bladder fullness and activity. So this will depend on how complete the lesion is and where that lesion is. So some of the things that we are worried about with this is if there's a difficulty in emptying, then we worry about urethral reflux and hydronephrosis that can damage the kidneys. This could be a significant trigger for autonomic dysreflexia. And so there are a number of adverse and significant impacts on health and quality of life. The way it's usually managed clinically, there are things like oxybutynin, these are anticholinergics. So what they do is this is a systemic drug taken, and it's usually an antimuscarinic if it can be specific enough. What it'll do is it'll relax the bladder, make it difficult to contract, but it also improves urinary continence. There's also catheterization strategies, many different catheterization strategies. What's considered a gold standard, if it's feasible to do, is clean intermittent catheterization. Certainly with any kind of catheterization, whether it's Foley or clean intermittent catheterization or anything that's going through the urethra, could be a trigger for urinary tract infection. So that is potentially a significant challenge. And then in the more extreme cases, there are surgical interventions like bladder augmentation, where a section of colon is surgically attached to a section of the bladder's opened up and a piece of colon tissue is attached to that to increase the bladder size. So there's a number of tools we have, but individuals with spinal cord injury are still having troubles. So we recently conducted a survey through the North American Spinal Cord Injury Consortium. This is a paper that just got accepted last Friday. So we're pretty excited about that. We surveyed, we received responses from at least 320 people. And we asked a number of questions about how are they managing their bladder, what are the challenges they're having, what priorities do they have if they want to get function back. And so I want to focus on a few things here. The first is the challenges that they experience. And the way we asked it was, in the last month, did you have this issue? And yes or no, and check all that apply. So you can see the top bar there is urinary tract infection. Approximately 240 people out of 320 experienced at least one UTI in the last year. Now that's at least one. We didn't ask them how many times they experienced this. We didn't get a sense of frequency of these issues, but we would ask how much it bothers them and these complications, and it was pretty high how much it bothered them. So urinary tract infection, urinary incontinence, and autonomic dysreflexia are three of the biggest challenges that they reported associated with their bladder management. If we ask them what their top priorities are, the first one is to empty the bladder without catheters. If they're using a catheter, they would love to be able to empty the bladder without having to use a catheter. And following that, we have maintaining urinary continence, and then being free of medical complications. That's usually with things like if they're having to use an anticholinergic medication and they're not thrilled with some of the complications that come with that. So this helps paint a clear picture of where we need to go with this work and what the targets are. So then we asked, any one of us may be concerned that, if I'm a guy with a hammer, do I see everything as a nail? And so I have a lot of experience with, neurophysiology and neurostimulation approaches. And so that's kind of the hammer I'm using. And I don't want to just assume that that's going to be what works for everybody or what they all want. So we specifically asked if you could use a neurostimulation approach to improve, for example, urinary continence without catheters or leakage or leg bags or absorbent pads. Would this be something you'd be interested in? And when we ask if they would take an implanted neurostimulation system, we see about 40% of respondents are likely to very likely to adopt an implanted system, which honestly was higher than I thought it would be. I didn't realize so many people would be so willing to consider an implanted system. They were concerned with some of the risks associated with the implant surgery, which is understandable. And then for an external system, obviously the rate of acceptance was much higher. So we're looking at well over 50% of individuals that are very likely, or at least likely, to adopt an external system to improve their continence. So we asked a number of questions like this to just kind of put our finger on the pulse, what it would be acceptable, and what would a solution look like, and how do we know when we've succeeded? What are those goals? So really, we're talking about a goal-driven solution for where success is defined by the people that would benefit from it. So we're going to take a break here to take some questions before I go on to some of the approaches that we're looking at. And I see that we have a couple of questions about the slides getting cut off. So
Yeah, it seems like the right side is a little bit cut off for everybody. So I'm not sure if there's a way to sort of resize them or what exactly.
That's a good question. And does Bethany have a suggestion on that? Because we're going to be on full screen on a...
Yeah, so I feel like I apologize again to everyone for this little technical difficulty. Deal with us for one moment. When you had in the practice session, when they were full screen, I felt like we could see them all more clearly. So if you would have go back to that last slide real quick, so that we can try messing with how you're doing the present.
It looks like it's getting cut off at the top and the bottom.
Yeah, it's sort of the top and then the right a little bit.
Indeed.
So if you maybe quit presentation mode.
Yeah. And then I'm going to go back into presentation mode. That did not help.
No, it's going to do this.
Here's what I'll do. And I apologize for the time this is taking. I'm going to try this one more time.
There we go.
There we go.
Okay, thank you for bearing with us, everyone. We'll pause here for a couple of seconds to let, if anyone has any questions, come back through the chat. Hand it back over to you, Jackie.
Okay, yeah, we'll give it a few seconds and see if anyone has any questions up to this point. Which it doesn't look like it so far.
And I can talk at great length just about bladder dysfunction and what that means for people. It is a very significant concern for quality of life and for health. One of the number one reasons for people to get to go back to the hospital after they've had a spinal cord injury months or years later is some complication with their lower urinary tract function.
Doesn't look like we have any questions. I guess we can move on for now. See, maybe when you get into the details.
That's fine. Yep, and if people have additional questions coming in, that's fine. So we're going to talk about urinary continence first, because that was one of the top priorities, not the number one. We'll get to that in a minute. But maybe the second priority first, I suppose, because we've gotten pretty far with that. So there are some neuromodulation approaches for overactive bladder. So for individuals that do not have a spinal cord injury, some of you may have heard of the InterStim system by Medtronic, which uses sacral neuromodulation. And so these are clinically available devices for overactive bladder. There's also posterior tibial nerve stimulation that's done as an outpatient procedure or outpatient visit. And these are using techniques of stimulating sensory neurons to modulate a bladder inhibition effect. And they show some effectiveness for people with overactive bladder, but we just don't have strong evidence for their effect in neurogenic bladder overactivity. So there's some debate there about could these tools work for SCI but what I'm going to talk about is something that has been demonstrated in spinal cord injury. It's not clinically available yet. This is something that we are working on, but it's got a few decades of history behind it. Going back into the 1960s, some clinicians noticed a reflex relating from the genitals to bladder inhibition, and by the 70s, they were testing different forms of electrical stimulation to try to get to the pudendal sensory afferents and modulate a bladder inhibition reflex. So what we do is we use so the top right figure is showing just sort of a block diagram of a urodynamics setup. So some of you may be familiar with urodynamics, but if you're not, this is a clinically standard diagnostic procedure to see what's going on with the lower urinary tract if someone's got a spinal cord injury. So they put a catheter through the urethra, and with that catheter, they can fill the bladder, and they can also measure pressure in the bladder. There's also a balloon catheter in the rectum, and that's just to be able to tell that, for example, if someone were to cough, that would cause a pressure spike on the bladder catheter. But if they see the same pressure spike in the balloon catheter in the rectum, then they know that that was someone coughing, and that was an artifact. That's not really the bladder. And then the signals can go into a data acquisition system, a DAC, and then to a computer. But we also have a stimulator that we can use to apply stimulation. So with genital nerve stimulation, we apply stimulation to the skin. So it's non-invasive, it's surface stimulation, because the genital nerve branch of the pudendal nerve is really superficial, and it's totally sensory. There's no motor function in that nerve directly. So this can work in men and women. We can apply these electrodes on the surface of the skin, and we can, it sounds a little bit unusual, to activate bladder inhibition reflex. Usually when we think of electrical stimulation, we're thinking of that we're getting a muscle contraction. And that's pretty intuitive. But what we're doing here is we're stimulating sensory neurons to modulate spinal reflex pathways. And so that reflex may be an inhibitory one. So here it's a little bit, it may not be intuitive at at first blush, but we can activate nerves to cause inhibition of activity. So we're inhibiting bladder activity. In the bottom left figure there, you see pressure over time, and that blue trace is the rise in bladder pressure that you would see in a bladder contraction, a reflex bladder contraction. So when we fill the bladder up with saline, the bladder will contract, and that's that blue trace. And that results in emptying. And so if someone were walking around in the world and this happened, that would result in urinary incontinence, a leak. But the black bar denotes the application of electrical stimulation. So plotted on top of this, we have the red trace, which shows, again, the bladder contraction is starting up. And as it starts up, we apply electrical stimulation, and the pressure comes down. So we are stopping that contraction in its tracks. And it's a pretty robust, strong response. So we and other groups have tested this approach. We published a meta-analysis a few years ago across 9 studies and almost 100 subjects. The bladder capacity can increase up to about 130 cc's by applying this. But this is all with acute genital nerve stimulation. We know it works in men and women. It doesn't matter what their capacity was or what their neuropathological origin was, whether it's spinal cord injury or something like multiple sclerosis, they could benefit from this. As long as they have this reflex and bladder overactivity, this approach could work. So what's really interesting, though, is what happens if we send them home with the device, over some chronic period. So we did a study, we published this a couple years ago, where we sent people home with basically a TENS unit, and we just needed to apply, say, 20 milliamps at 20 hertz, thereabouts, and they could, whenever they felt urgency of the bladder, they would turn the device on, and the urgency would go away, and then they'd either keep going about their day, or they'd find their way to a washroom so they could empty their bladder. If they did not have that sensation, they would tend to leave the device on. So here's data from 4 individuals that we've got in that right-hand plot, where they had some significant incontinence. At least approximately once a day they were leaking, and it was not insignificant leakage. And then 3 of those individuals were virtually completely dry with stimulation. And then that 4th individual, you see the triangle doesn't come down a whole lot. What they did report is the severity of the continence was significantly decreased. So they still had an incontinence episode, but it was, instead of a full bladder emptying, it was a few drops. So this study adds to a few other studies that were conducted in the literature, where subjects would have, it's usually small numbers of subjects for a month or so. But when we put these together, we see some supporting evidence that there's a practical clinical impact from using the system. And we get some interesting, I know it's anecdotal, but we want to understand, when people are using the system, what real world benefit do they get from this? What does it mean for them when we're able to help them inhibit their unwanted bladder activity? So we had, these are not photographs of our actual subjects for their own identity protection, but we had a gentleman who would go on long bike rides. He was still pretty active in spite of his spinal cord injury, and he could stay on a trail for a couple of hours at a time on a bike without having to worry about where the washroom was. We had another gentleman who liked camping with his buddies, and a couple of weeks in to the study, we were talking to him on the phone about how things were going, and he was complaining. He said, I was during the day and day to day, this thing is working great. But I was camping with my buddies last weekend, and I had to keep going up and going to the bathroom. Like, I don't think it was working well. I checked the batteries and I checked the electrodes, and everything was in place the way it should be. And so we asked him, I said, are you having beers with your friends there? He said, well, yeah. I said, maybe they're getting up to go to the bathroom too then? And he thought about it. I said, yeah, okay, so we're all getting up to go to the bathroom. And so this thing is not perfect. It's not just going to stop the bladder no matter what. The bladder is still going to keep filling up, and there's a point where you will need to empty it. But it was able to bring these people more into their social life and reduce that barrier a bit. There's always room for improvement. We had 3 main issues reported to us that was affecting compliance. So we were using off-the-shelf components, as you do often in research, instead of having some custom designed things. So the stimulator was considered bulky with long wires and tethering. So we had a battery controlled device. They weren't tethered to a wall outlet, but still having the wires from the device to a switch or electrodes was irritating. There's one gentleman who wanted to golf and had to take it off for golfing because it was getting in the way of his swing. But for everything else, he liked having it on. We had a model study design where we did daily voiding diaries, and they didn't like having to do that. So whenever you're thinking about doing a human subjects trial, think about how do you get your data from your study participants in a way that is not putting too much of an inconvenience on them. And then reliable feedback of bladder fullness is often needed. So this is what's called open loop stimulation, where we either just leave it on, or someone has some sensation of when they think they need to turn it on, and they turn it on when they think they need to. But that means they have to attend to those bladder sensations all the time. If they don't have sensation, they have to just leave the stimulator on. And they have to have the ability to manually activate that stimulator at a moment's notice. So, we've been looking at how do we make this more automated, because for those of us without a spinal cord injury, this is it's an automatic thing. I don't have to think about how my bladder's doing all the time. And I have automatic inhibitory pathways to take care of things. So we have another study where we've been developing a bladder sensor. And that bladder sensor can go into the bladder and telemetrically give us information about what the bladder pressure is. So if there's a bladder contraction, we'll see it. We also developed an algorithm that can continuously monitor the bladder pressure data to tell us if there's a contraction happening and tell us within a second or two of that event. So with that sensor, we can do things like put it into diagnostic systems or help with sensory improvement. But we looked at what if we use this for telling us when to stimulate. And there's some history of this. If we look at a bladder catheter, like in urodynamics, that bladder catheter can give us a pressure readout, but that means someone has to keep a catheter in their urethra the whole time. So there's been some data on this, but the algorithm was also very crude. It only looked at a simple threshold, and that's also not something that's going to work very well if someone's moving around or has artifacts like from coughing or shifting. But the idea is that when there's a bladder event detected, the stimulator is turned on and then turned off again when the bladder event is over. So we did the same thing, but we used our custom algorithm, which is able to distinguish between a bladder event, like a contraction, versus something else, like if they cough or laugh or talk or shift their body or something, or if they're walking around. So we've started, this is a study that we started, I'll share some preliminary evidence from this. But what we do is we start off with a catheter-based pressure measurement, and our algorithm listens to that, and it determines when stimulation should turn on and off. We've also been moving toward using that bladder sensor that I showed on the previous slide to do the same thing, so they don't have to be sitting in a chair for the experiment. They can walk around and do things for, during the normal day and try out this experiment. So we're calling this automated closed loop genital nerve stimulation. It does inhibit contractions in real time by having that sensory feedback, and we get some false positives. This may have to be tuned a little bit to each individual, but in 4 subjects we inhibited lots of contractions. It was well tolerated. One of the things you think about is if stimulation is being activated and it's not under your control, is that going to bother you? Like if you can feel stimulation and it's just turning on whenever, is that going to be perturbing? And in this case, it wasn't perturbing because it turned on when they thought it should, and the stimulation did not feel perturbing, and then the urgency went away right away. So it could take about 4 seconds to detect a contraction that could be reduced, but the stimulation was only needed for 2 to 4 seconds. It only took a brief amount of stimulation for the contraction to be stopped. So this kind of experiment is starting to give us some new insights into how this bladder activity is controlled and what's needed to get it under better control. In the past, we thought we would have had to leave stimulation on for 30 to 60 seconds, maybe longer. And now we're finding out that we only need it for a few seconds at a time. So this kind of work is kind of at cutting edge for what we're learning about the neural mechanisms underlying bladder function, but also giving us some insights into what a solution might look like if we have a sensor that we can use. So I'm going to take a break here to answer some questions about our bladder inhibition strategies.
Okay, perfect. So now we have a bunch of questions for you.
All right.
So right when we kind of got back into it, Lana from Drexel, where I used to go, she's now in California, but she had a question going more back to the intro slide. So this was, what is the risk of infection and or foreign body response with these implanted devices? Right.
So in our survey, we looked at devices that have been implanted to give a range of what some of these risks might be. We didn't specify a particular device for that survey. We were generalizing. And any follow-up survey, I should say, should specify a device. If there's something specific in mind, the survey would have to be done again with that device. The risk is, so this paper also just got accepted, where we do list some of that out. So I don't want to get it wrong by misremembering, but we're looking at probably a 5% um, risk rate for infection. It's not zero. It's not trivial. So that amount of risk should be always a bit of a concern. But the use of IPGs is becoming quite commonplace. Now, maybe this is a bit. I don't want to be too controversial here. In the urology community, they're adopting some of these implantable systems more readily because they're seeing that the risk benefit is certainly in favor of implanting the device some frequency. So the Medtronic InterStim system, for example, here in Cleveland, is being implanted with some regularity and quite a bit of success. But that's not to say that the risk is zero, and that should always be discussed. And the risk for different implantable stimulators is not all the same. So if we were just putting an IPG under the skin, an implantable pulse generator under the skin, the risk of infection for that may be different than if we're putting something into, say, bone. And there are other risk profiles that may be different. So we look at how invasive is this? What kind of electrode interface are we using? So I get a little bit more concerned about the implanted electrode, where the risk profile can be something more variable, and it's difficult to just look at other devices that have been implanted and take a lesson from them. So I would say probably about a 5% risk of infection.
Great. Okay, next sort of also kind of with the intro a little bit, Megan Detloff from Drexel asked, how prevalent are bladder infections in terms of also the overactivity and underactivity? I'm assuming she's referring to NSCI patients.
All right, I'll answer that for a minute. I'll take it. So from our survey, we found that the vast 240 out of 320 respondents that we included were reporting a UTI at least once in a year. I'd have to look at the literature to get a better answer about how frequently urinary tract infections happen. But when we ask them what bothers them, the urinary tract infections are very bothersome. Even if it happens once every 4 months, I'll say if it happens once a year, that's considered very bothersome to them. Because the urinary tract infection can get pretty bad. So I'm sorry, I don't have a number handy for that answer, but it is not trivial. And that is why the number one, I think that's part of why the number one priority for individuals was to be able to enter the bladder without catheters. I think that's one reason.
For sure. Okay, awesome. Next question was, they said it's a naive kind of general question, but is the autonomic control of bladder purely spinal mediated? Is there a role of the supraspinal structures such as the motor cortex involved in visceral motor control? Could CTX be a target?
That is a great question. So there are supraspinal control centers. The pontine micturition nucleus is an example. There is some cortical contribution, but most of the main control that's supraspinal is subcortical. So I would hesitate to think that there's going to be a cortical target. But when we look at there's some very interesting neurostimulation approaches that have been put forth for, say, upper limb and lower limb function, musculoskeletal function, where they stimulate above and below the lesion, and depending how they time the volleys, they'll try to strengthen some of those pathways that still exist through the lesion. So I think there's some value in looking at some of the brainstem and supralesion targets, but maybe less so with the cortex.
Okay, perfect. All right, so we're actually going to skip Megan's second question. The next question was, which I might butcher this name, Hadi. I don't know if I'm saying that right, but she wanted to know, did you check EUS function after the nerve stimulation in addition to cystometry? Because I guess her concern was looking at DSD as the major problem after SCI as well.
So we absolutely do that. Every study participant is evaluated for what their dysfunction is. So we want to know, do they have neurogenic decreased reserve activity? Do they have DSD? What's that going to mean for their function? We also kind of, I think of this as kind of an a la carte approach. You know, we want to add tools to what exists. We're not trying to be, we don't want to be arrogant and say we're going to completely replace what's out there. But if we can add to or augment what's out there, that we think that's a worthy goal. So if we think about continence and emptying as two different challenges, we have an approach using gentle nerve stimulation that can help with the continence part of the challenge, but it doesn't have an effect on the sphincter, beneficial or harmful. Same thing with autonomic dysreflexia. There's been a prospective study, more than one, that asked, could stimulation be a trigger for autonomic dysreflexia? And in fact,
some of the questions did ask that too. They were asking what happens with.
So it is not going to trigger autonomic dysreflexia. It's not going to have negative side effects. It's not going to allow your bladder to get full to a point where you have a problem. It can't get over full. There is a point where the bladder gets so full that the stimulation is not going to help anymore, and you're going to have to empty. But it doesn't have we don't see an appreciable effect on DSD. So it really goes into focus to, can we inhibit the bladder overactivity, up to a higher volume.
Right. Okay. Perfect. Okay. And another question, which we might have to be our last one, but we still have a decent amount of time. Did you check sexual function after the nerve stimulation? So things like ejaculation, emission, and expulsion phase. Could the stimulation affect expulsion phase as a side effect?
So we definitely ask about that. Our study participants are active in many ways, not just on a trail, and they would certainly ask these questions and follow up on that. And so to directly answer the question, no, there's no effect for better or for worse on sexual function or sensation that we could perceive or measure, or that was reported to us. And we did specifically look for that. So we didn't see an effect on sexual function.
Okay, perfect. So I think for the most part, we touched on most of the questions for now. And if not, we can bring them back up at the end. So we can get right back into it.
Right. So this is the third and final section that I'll go through on bladder emptying. And remember that the number one, so we've been focusing on, this is going to be much more recent and maybe cutting edge work. This is not necessarily sitting on decades of previous work, but it's also the number one priority. And so since polling individuals with spinal cord injury, what are your priorities? We've been trying to put more emphasis into this as a target. Can we help someone empty their bladder without a catheter? And so some of you may be familiar with sacral interior root stimulation, especially the Fintech Ridley system. It used to be available in the United States, and it was called the Vocare system. Now, it is no longer available in the US, and this is one of the, I won't spend too much time on this, but I could. One of the challenges with serving the population of individuals with spinal cord injury is that it's not considered a large market. And so when you have something, when you're working with a for-profit motive in healthcare, and a company is trying to make a profit by selling a device, they really need to understand their market and do a good job at meeting that market need. The company that was selling Vocare in the United States, they went out of business. I don't have the whole story on that, and I will not make that a part of this talk. But the short answer is, it used to be available, and it's not because of industry reasons and not because of science reasons or engineering reasons. This is still available in Europe, and the system does work. So the way it works is electrodes are implanted at the sacral roots. Usually it's left and right, S2 through S4. And the electrode leads go up to an inductive coil. And that inductive coil and electrode leads are all under the skin. So a neurosurgeon will implant this with a laminectomy, and it'll be maybe a week or less of hospital stay to recover from that. Now, on the outside of the skin, there's another, so I just described A and B, the electrodes on the sacral roots and the receiver coil. Then there's parts C and D, the transmitter coil and the controller. Those are on the outside of the body. So if you meet someone with this device, you won't know they have it in them because you won't be able to see, you're not going to see wires sticking out of them. They'd have to show you the very small bulge that is that receiver coil under their skin, and that's going to be pretty discreet. But when they want to empty their bladder, this is also for emptying bowels or for improving sexual function. Those are also indicated here. But when they want to empty, what they'll do is they'll put that receiver coil, the transmitter coil, C, over on the skin on top of where the receiver coil B is. And so they'll get transmission through the skin, coil to coil, using a magnetic inductance transmission of power. And they'll turn the controller on to the program for, say, emptying their bladder. And then what I'll do is I'll transmit a signal through the coils to the leads and then to the electrodes, which will stimulate the sacral roots with the appropriate pattern to get the motor efferents to drive the bladder to contract. And so this is a device that gets the bladder to contract on demand. Now, there are a number of challenges with this. A lot of people have reflexes, as we talked about in the first section of this talk. And these reflexes can make it difficult to empty. And so what's typically done is what's called a posterior rhizotomy, where the sensory nerves of those sacral roots are cut. And so that way, there is no reflex that will get in the way of emptying. There's also no reflex that would cause the truser overactivity. So this tends to improve continence and voiding. And so, I would look at the system and say, oh, we're done. This is great. This device works. And it's very effective. It's been implanted in thousands of people that have pretty happy with it. It's cost effective. That study's been published. But the problem is with the rhizotomy. So it does abolish any remaining pelvic sensation that someone would have had. It abolishes any desirable reflexes like sexual function. And so that rhizotomy ends up being a barrier. And this does require surgical implant. So this is a third tier. This is along lines of surgery. So these are the things that we have to think about. Now, the rhizotomy is where we're focusing in. And so there are a couple of things that we think about with the rhizotomy, that we think we do for the rhizotomy. So if any of you have gone to the dentist to get a filling and they inject Novocaine into your gums to numb the roots to your teeth, so you don't feel them putting in a drill, that lidocaine is chemically blocking the nerves, so you can't feel anything. And so, we're looking at, can we do something like that that's electrical? So it doesn't have to last for hours. It just has to last for seconds or minutes. How do we reduce the activity that we would have seen without having to cut the sensory nerves? So what we've defined the problem as, we want to reduce the urethral sphincter activity, whether it's reflex or direct driven. Either way, we want it reduced so that that doesn't stop the bladder from emptying. So there's a couple of approaches we're looking at. And one of them is if we stimulate at 200 to 600 hertz. This is something that's been shown to deplete neurotransmitter rapidly, and it's rapidly reversible. So basically, imagine something like rapid fatigue. Now, I hesitate to use the word fatigue because at lower stimulation frequencies, fatigue means something different. And that's not what we're talking about here with fatigue. So think of it as a rapid depletion of neurotransmitter that is also rapidly reversible. So when we apply I'll walk you through this figure. In an experiment in animals, we had a catheter in the bladder, and the bladder had some volume in it, so we could contract and we could see the pressure. We also had a catheter at the anal sphincter, because we could not fit in this animal we didn't have a catheter that could tell us the bladder pressure and the sphincter pressure at the same time. in the setup. So we used the anal pressure as a proxy for urethral pressure. But honestly, we want both of those to be reduced. So this is a valid setup in my opinion. Now we used 20 hertz stimulation, that's the dashed green line, and that was to evoke activity. So we stimulated a sacral root at 20 hertz to evoke activity. And we could, in the red line shows the anal sphincter pressure. When we turn on stimulation, we got the anal sphincter pressure right away. It turned on fast and it stayed on strong. But we didn't turn it up high enough to also get the bladder. Okay, so in that first bit, the first 2 to 4 seconds or 2 to 5 seconds, you see only the sphincter is turned on and is only responding to the sacral root stimulation. Now, then what we did is on top of that, on another electrode kind of further down the nerve, we applied stimulation at 600 hertz. And what you'll see is that this is happening simultaneously with the 20 hertz. Okay, so you have 2 electrodes next to each other, and one of them at 20 hertz is activating, and then further down we have the 600 hertz, and we saw a significant reduction in that anal sphincter pressure. Now, in this example, we're also seeing a rise in bladder pressure. So further work is needed to determine if that is consistent, if that 2 to 600 hertz stimulation gives us reduction in somatic muscle responses while not affecting bladder or activating bladder. But we do see a repeatable effect of being able to use electrical stimulation instead of cutting the nerve to reduce that sphincter activity. We also have another approach that we're simultaneously looking at, which is at 10 kilohertz. So it's a different frequency, a much higher frequency, which also uses a different mechanism of action. So in this mechanism, we're blocking conduction of propagating action potentials. Basically, in where the electrode is, action potentials cannot get through. And this has been done in a number of other experiments. So we're kind of standing on the shoulders of other people that have tested it in skeletal muscle. So we've tried this on sacral roots and benedyl nerves and found that it is very effective at inhibiting sphincter activity to the point that we've even done a chronic experiment with an implanted electrode to demonstrate that. The challenge here is having a device that we can use in human study participants that provides this 10 kilohertz frequency in a way that passes also regulatory approvals. So we have these 2 different approaches that we're right now looking at simultaneously, and either of them have a chance at replacing that rhizotomy, so we could bring that fine text stimulator back essentially. So in conclusion, we have genital nerve stimulation that can strongly reduce bladder activity, improve urinary continence. We have the opportunity for real-time automated closed-loop genital nerve stimulation, and it may be feasible. And then we're exploring stimulation alternatives to that posterior rhizotomy to achieve efficient bladder emptying. I'd like to acknowledge some of my collaborators and trainees that have helped along the way with some of these, and our funding institutions that have made this possible. All right. Any questions left now?
Okay, yeah, there were actually 2 that we didn't quite get to in the last portion. So the first question is from Sasha Robcheski. He was asking, what measure would you use for perception or urge with a complete spinal cord injury, and how essentially you would be able to establish stimulation cutoff? Because if you have to sort of max it out, was sort of his question.
Right. So we have a max cutoff so if someone has no perception of stimulation or bladder fullness, then we don't have to go higher than 40 or 50 milliamps on the stimulation. And we already know that there's an upper limit that we would work with. But this is where we would like to develop the sensory technology, because if they don't have any of this perception, then what they would do is they use the device and just leave it on for 6 hours at a time, and then build that into their routine. But if we can bring in some sensory feedback from a safe implantable sensor, then that would close the loop and give them that sensation. And we have a vision for how that could work.
Cool. Awesome. Okay. And one of the last questions was from Tracy Wheeler. The question was how preclinical researchers can or should incorporate consumer politics.
Consumer priorities. Yeah. So one of the papers that we just got accepted was for a roadmap for advancing neurostimulation approaches for bladder and bowel function. And we do reference the survey in that roadmap, but we also talk about the importance of including consumer priorities and perspectives in that roadmap. But that lesson applies beyond neurostimulation and applies beyond bladder and bowel. I think that I strongly believe that any of us that are trying to have a clinical impact require that input from the consumer to define what the priorities are, to help define what success looks like, and to help guide how we would translate our discovery work and preclinical work into what a human or a clinical application would be. So there are a number of factors we tend to think about in the science realm, which is, what's the mechanism of action, and do we have something that we would call a treatment? But the more we can understand the experience of the person with spinal cord injury, the more successful we'll be in our preclinical work, and also I think the more satisfying it's going to be if we can see our preclinical work translate. Factors such as mobility, access, and cost are not trivial, and we want to consider those when we're looking at what we're pushing on.
Okay, awesome. All right, so I think that was actually the last question, unless any more stragglers kind of roll in, but it seems like there's kind of a conversation amongst the group, so.
Okay. So as Bethany said, I am happy to go on to the YouTube channel, and I can continue the conversation there if people are interested. And is that what we want to do?
Sounds like a plan. Thank you very much. So Jaki, go ahead and.
Sure. Okay, so next week we're going to have our Trainee First Tuesday, where a few of us are going to be presenting, including myself. So come back then and listen to some of us talk about our work.
All right, great. So thank you very much. As Dr. Bourbeau said, he'll be in the chat for a little while if you have any additional questions, or looks like there's some interesting chat going on regarding magnetics and additional stimulation. So I'll leave that open for a little bit. Like we said, make sure you hit the like and subscribe. We have IOSRT month coming up. And thank you again very much, everyone, for joining us. It's a highlight for all of our weeks, and we look forward to seeing you next week.